Statins aren't good or bad, they're a risk reduction tool, and the real question is, what's our risk, and what's the smallest move that actually changes the outcome? Because the internet turns statins into a weird personality test, where one side treats them like poison and the other side treats them like a free pass to ignore lifestyle. At Longevity Compass, we're not doing either. We're doing a calm decision tree using 3 things that matter: risk, ApoB particle traffic, and whether we already have plaque receipts. By the end, you'll know when the smartest answer is start, when it's don't start yet, and when it's reassess with better data. First fork: primary prevention or secondary prevention. Secondary prevention means proven disease, heart attack, stroke, TIA, angina, stent, bypass, or peripheral artery disease, and in that lane statins are usually foundational because we're preventing the next event, not debating theory. Primary prevention means no known event yet. Here, we're deciding whether long-term plaque risk is high enough that lowering particle exposure now changes our future. And before we talk numbers, we need one reframe that instantly lowers anxiety. The statin debate is not about cholesterol feelings, it's about plaque math. Atherosclerosis is a long, slow process of plaque building in artery walls. Statins reduce events mainly by lowering the atherogenic particles that drive that process over years. And the cleanest way to explain those particles is ApoB. LDL-C tells us how much cholesterol is riding inside the trucks. ApoB tells us how many trucks are on the road, because each LDL, VLDL, IDL, and LPA particle carries one ApoB. For plaque risk, truck traffic matters, and that's why 2 people can have the same LDL-C and different ApoB, meaning different particle counts and different risk. So in primary prevention, step 1 is, what's our risk profile and what's our particle burden? Risk profile includes age, blood pressure, smoking, diabetes, kidney disease, family history, and risk enhancers like high triglycerides or high LPA. Particle burden includes LDL-C and non-HDL-C, and ideally ApoB when triglycerides are high or insulin resistance is present. Now comes the part where most viewers get stuck, the gray zone. LDL isn't outrageous, we feel fine, and the advice sounds like maybe, while the internet yells never or always. This is where one test can turn fear into clarity: CAC, coronary artery calcium. CAC is a scan that looks for calcified plaque in the coronary arteries. It doesn't replace cholesterol math, it complements it, and it gives us something the internet can't argue with: evidence of plaque burden. CAC doesn't tell us whether cholesterol matters, cholesterol still matters, but CAC tells us whether the body has already started leaving receipts. Here's the calm CAC tiebreaker logic for borderline or intermediate risk people. CAC equals 0 often means no detectable calcified plaque yet, which can support delaying a statin in many people as long as we don't have major exceptions like diabetes, smoking, LDL-C at 190 or higher, strong premature family history, or very high LPA. CAC 1 to 99 means plaque exists, and the conversation tilts toward treatment, especially if we're older. CAC 100 or more is a strong signal that we're not guessing anymore, we're managing existing disease burden. And the nuance matters. CAC equals 0 is not invincibility, it's low short-term risk, not zero lifetime risk, especially in younger adults who can still have soft plaque. So we don't use CAC to avoid responsibility. We use it to choose the smartest intensity of prevention. Now let's build the actual decision tree in plain English. If we're in secondary prevention, we usually aim for strong LDL and ApoB lowering because the house already had a fire. We don't argue about smoke alarms after the fact, and we don't gamble with good enough when the goal is preventing the next event. The job is lowering risk and making the plan tolerable. If we're in primary prevention, we ask 3 questions. 1. Is baseline risk high enough that lifestyle alone is unlikely to change outcomes fast enough? 2. Is ApoB or non-HDL high enough that arteries are seeing heavy particle traffic? 3. Is CAC needed as a tiebreaker, or is risk already clear? If risk is low, particle burden is reasonable, and there's no plaque signal, lifestyle first is often the smartest first move with a defined reassessment window. If risk is intermediate to high, ApoB is high, LPA is high, diabetes is present, LDL is very high, or CAC shows plaque, then a statin is a very reasonable smallest move because it changes the odds meaningfully. Now let's address the part that makes statins emotional: side effects. First, muscle symptoms are real, but real symptoms do not always mean the statin is the cause. In blinded trials, many people report similar muscle symptoms on placebo, which doesn't dismiss anyone. It just reminds us that expectation can amplify normal soreness into this medication is destroying me. So our rule is calm testing, not gaslighting and not dramatizing. If muscle symptoms show up, we troubleshoot timing, training changes, dehydration, illness, thyroid issues, vitamin D status, and drug interactions. If symptoms are significant, clinicians may check CAC, and liver enzymes are often checked before starting and rechecked if symptoms suggest a liver issue. Then we adjust instead of rage quitting. Options can include lowering the dose, switching to a different statin, trying a hydrophilic statin in some cases, or using alternate day dosing for selected people under clinician guidance. And if true intolerance exists, there are non-statin add-ons like ezetimibe and other therapies that lower LDL and ApoB without forcing the same approach. What about CoQ10? Here's our calm take. It's biologically plausible and popular, but evidence is mixed, so CoQ10 is not mandatory statin armor. If someone has muscle symptoms and their clinician agrees it's reasonable, a short CoQ10 trial can be fine, especially if it helps them stay on therapy they truly need, but it's not the core strategy. Now the nuance people deserve. Statins carry a small increased risk of new-onset diabetes, especially in people already near the edge. So if someone has insulin resistance, higher fasting glucose, metabolic syndrome, or obesity, the answer is not fear, it's monitoring plus stacking habits that improve insulin sensitivity. Lift, walk, sleep, fiber, protein, and waste reduction if needed, because that's how we protect metabolism while we protect arteries. And now the last myth. Once you start, you're trapped forever. Sometimes long-term therapy is appropriate, especially in secondary prevention or clearly high-risk primary prevention, and the real concept is cumulative exposure. Plaque risk is a lifetime math problem, and lowering ApoB exposure meaningfully over years changes the trajectory. So the question isn't do we like taking pills? The question is do we like heart attacks and strokes? We're not saying that to scare anyone, we're saying it because it's the point of the whole conversation. Now here's the clean longevity compass start, don't start yet, reassess framework. Start, or strongly consider starting, if we're in secondary prevention, if LDL is very high, if diabetes plus other risk factors are present, if ApoB is high with risk enhancers, or if CAC shows meaningful plaque. Don't start yet if risk is low, ApoB and non-HDL are reasonable, CAC is 0 when used appropriately, and we're willing to execute lifestyle hard for a defined window. Reassess if we're in the gray zone or the data are incomplete, because that's where ApoB and LPA testing, and selective CAC, can turn guesswork into clarity. Quick safety note, this episode is educational, not personal medical advice, and statins are prescription medications that should be decided with a qualified clinician. If you're on a statin, don't stop it without talking to your clinician, especially if you have known cardiovascular disease, and if you have chest pain or stroke symptoms, get medical care. Now a simple action list for this week. If you don't know your ApoB, ask for it, especially if triglycerides are high or family history is strong, and if you're on the fence and borderline or intermediate risk, ask whether CAC makes sense as a tiebreaker. If side effects happen, don't suffer in silence and don't panic, quit, document symptoms, then troubleshoot dose, type, timing, interactions, and alternatives with a clinician. And no matter what, execute the levers that lower risk in every universe: blood pressure control, resistance training, steps, sleep, fiber, and fewer ultra-processed calories. If this helped, hit like and subscribe, and check the description for tools and affiliate links that match today's episode, plus our Longevity Compass Amazon KDP book. Comment your lane. Primary prevention, secondary prevention, are still in the gray zone, because we read the comments and it helps us build the next episodes.